Good morning. It's Wednesday, December the 7th. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System, and this is Show Me the Science. If you suffer chronic back pain, you are not alone. Back pain is one of the most common complaints, forcing people to call off work and sending them to the doctor. In addition, it can lead to depression, anxiety, and missed time with family and friends. And yet, despite this widespread common problem, back pain is not a one-size-fits-all. Neither is pain management. If this sounds like you may be just the person who we are looking for to participate in a multi-center study funded through a National Institute of Health grant, awarded to only 13 sites across the country, and we are one of them. We're going to put up the QR code so you can take a look and learn more, as I suspect many of you will want to participate or share with someone. Use the QR code on the screen or go to besttrial.org. The principal investigator for the study is Dr. Andrea Chadwick, director of the FACE lab in the Department of Anesthesiology here at KU. FACE is an acronym for Fibromyalgia and Centralized Pain Exploration. She has invited one of her back pain patients to join us. We're going to hear from Danelle Ragsdale about their back pain and why they signed up for this study. Also with us in studio is spine surgeon Dr. Joshua Bunch, who will talk about when to consider surgical interventions. And of course, Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, will join us shortly with our trifecta count of COVID, RSV, and flu cases. And Hawkeye, we're going to talk about one more guy who may be working home today because he falls into one of those categories. We'll talk about what that's like too. So we'll first of all get to it with Show Me the Science, which was created to help viewers know more about how research is conducted. This study is a randomized controlled trial with 4 interventions. Let's define this trial and those interventions right now. Dr. Chadwick, thanks for being in the program today, and congratulations on doing this really important study. The study is called BEST, which stands for Biomarkers for Evaluating Spine Treatments. What is the main goal of the BEST study?
Well, first and foremost, Dr. Stites, I want to say thank you for having me here today, and I'm excited to talk about this very important trial here in the studio. So the goal of the study really is in the name. So it's biomarkers for evaluating spine treatments. So the ultimate gist of the study is to identify patient characteristics, and we're using that term synonymously with biomarkers to identify if there's or what we call baseline characteristics of patients that may predict that they respond better to certain treatments for chronic low back pain to the other. So as you said, there's 4 interventions which are all evidence-based in how they treat chronic low back pain. But as you mentioned, chronic low back pain isn't one size fits all for patients, and that's because chronic low back pain itself is very different in how it presents or develops in our population. And so the study is aimed at trying to personalize pain treatments for patients with chronic low back pain based on who they are.
Thank you. Dr. Chadwick just said that's a great looking Christmas tree back there.
I mean, I couldn't have asked for better.
Spirit. That's awesome. All right.
I mean, ho, ho,
so
ho.
As doctors, we use, I know. As doctors, we use biomarkers such as heart rate and blood pressure in caring for patients. What biomarkers will you measure for your study and how? And tell me what you're going to learn from those biomarkers.
And that's great, because I think it's really important to talk about biomarkers in the clinical and then in the research sense. So a lot of different biomarkers, as you mentioned, heart rate, blood pressure, can be used clinically to inform practice. And in research, we use biomarkers to basically measure different traits or characteristics about a patient. So within the BEST trial, all participants will have a variety of tests and questionnaires administered to them. So patient-reported outcomes will be administered to all participants, and these are meant to measure a variety of different facets that we know exist in chronic pain. So that can be pain severity, the type of pain they're experiencing, and also how their pain affects their physical function, their fatigue, their sleep, and their enjoyment with social activities. aside from that, we are going to utilize spinal imaging and biomechanics. So it's kind of cool. We get to place these markers on patients almost like a green screen and watch them walk and stand to see if the way that their gait is or the way that their posture is may identify a certain type of treatment that would work better for them. Additionally, patients will have some blood work done, and that blood work is sent off to the lab to be processed for levels of inflammation, which we know can be present in patients with chronic pain, as well as for genetic analysis. Now, a subset of patients will have additional testing if they elect to do the deeper levels of biomarkers, and those include advanced brain imaging to see how the brain is processing pain, as well as advanced spine imaging. And then finally, we utilize in my lab, outside of this study, but definitely for this study, the patients who elect to do the deeper phenotyping will have something called quantitative sensory testing done, which sounds a little frightening, but it's actually really cool. It allows us as researchers to use a variety of machines and tools to elucidate how a person's central nervous system and peripheral nervous system are processing pain. So it allows us to elucidate how sensitive they may be to pain or if they have high pain thresholds.
Oh, that sounds really important. And I think what an advance for science that would be if you could use the biomarkers even for helping categorize what type of treatment people get. That is remarkable. So participants in the BEST trial are going to receive one or two of the following 4 treatments. And normally we don't say 1 or 2 in research, but this is important about why. So we're going to talk about that too. So receive 1 or 2 of the following 4 treatments have been shown to be effective in treating chronic low back pain. So this first part is acceptance and commitment therapy, and it's one of the treatments being studied. What does that mean?
So acceptance and commitment therapy, also known as ACT, is a form of cognitive behavioral therapy. So we know that pain in and of itself is a physical experience for the patient. You feel pain, but there's also a psychological component to pain in that the patient is experiencing feelings about their pain. And so what ACT does is it tries to focus on discussing with a pain psychologist how the patient feels about their pain and acts in their life based on how that pain makes them feel. So the ultimate goal is to empower the patient to recognize and accept, as you can tell, that's part of the therapy, is acceptance, in understanding that the ultimate goals of treatment in patients with chronic pain is not a full elimination of the pain. It's how can we reduce the impact that the pain has on their lives by recognizing the values they have for their life and understanding how they can commit to goals and behaviors and changing their emotions and feelings surrounding pain so that they can reach those goals and commit to things that improve their life.
That sounds really, there are so many ways if we could do that, we would improve the outcomes in a lot of disease or how people just cope with it. I think that's great. So some participants are going to receive the FDA-approved medication duloxetine. Describe this medication and how it works and the side effects it has. What's it doing for folks?
Duloxetine is FDA approved for the treatment of chronic musculoskeletal pain, of which chronic low back pain is a diagnosis within that spectrum. Duloxetine is a serotonin norepinephrine reuptake inhibitor, which means it blocks the reuptake of these molecules known as serotonin and norepinephrine and allows them to participate in functioning of pain processing in the brain. And we know that these molecules are very important in helping the brain inhibit or dampen pain. So by having more of them, it helps the patient have less severe pain and less perception of pain. And as far as side effects, we know with medications that there is the potential for side effects. This medication is often very generally well received and tolerated by patients, but the most common side effects are gastrointestinal upset and drowsiness, many of which patients experience that they get better over time, typically about 2 to 3 weeks of those symptoms, and then they'll abate.
So it sounds a little like a Jedi mind trick. Pain you do not feel. All right. Some participants are going to be enrolled in an enhanced self-care online program learning module that includes evidence-based strategies and life skill strategies, lifestyle skills. What kind of strategies and skills specifically? And is there a role for exercise in here too? Because I'm fascinated by that question.
Absolutely. So this is a really great arm. It's actually intended to be somewhat of a control arm, but it still allows the patients to have some control of improving lifestyle modifications and strategies, as you said, to help with their pain. So this was based off of Pain Guide, which was developed at the University of Michigan, and it's an online set of modules which really focus on the tenets of movement and activity, exercise being a part of that, as well as concepts that are similar to acceptance and commitment therapy. So a big part of the enhanced self-care will be focused on goal setting, improving activity, and improving the ability to exercise. And for all participants, they will receive education on pain, as well as pain mechanisms, because there's a lot going on in how pain is processed within the body. And then generally speaking, many of the modules will just give an overview about the different treatments for chronic pain. But what's really cool about this is all patients will receive a Fitbit that allows them to track their activity. And part of this module, this enhanced self-care, is a structured walking program that will allow them to gradually increase their walking so that they incorporate that into their lives more regularly. And then the Fitbit gives them that information, kind of that feedback on how they're doing. And then the second part of the enhanced self-care, which is also really neat, is that the baseline characteristics, remember I told you about those cool questionnaires that patients take, they actually impute that data into the patient's module, and they're able to kind of target specific things that personal patient is experiencing. So for example, if a patient fills out their surveys and they score really high on sleep-related impairment, meaning sleep is a really big problem in their lives, they are able to push those types of modules towards the patient through emails and texts to be able to focus them on those things that are impacting them more. They will have access to all the modules, but it allows for that personalized care again.
You know, that is pretty cool. And let's get through our next question, because I want to kind of come back to the whole setup of this. So, you know, we know the treatments in your study have proven to be effective in and of themselves. We also know they don't work the same for all patients. We've learned that the primary goal for the best trial is to determine which treatment or combination of treatments work best for a particular person. That's pretty impressive work. I mean, it's a pretty impressive trial design. It's pretty extensive. So just real quick, before I want to turn to your patient here in just a moment, but before we do that, how did you get involved in this? Where did it come from?
That's really a great question. So I've had the pleasure through some of my other grants to develop collaborations with Dr. Daniel Claw, who is the director of the Chronic Pain and Fatigue Research Center at the University of Michigan. And he is one of the lead investigators on the NIH HEAL Award, which is entitled Backpack, and they are focused on performing research for chronic low back pain. So I was contacted by Dr. Claw and asked if I would be interested in running this trial at the University of Kansas, and I put our name in the hat to be able to be potentially selected as a site. And considering that I have expertise in patient-reported outcomes, quantitative sensory testing, and neuroimaging from my other research, they felt that we were a really great site to be involved.
No, that is okay. So here's a little personal story. So I had terrible back pain myself a long time ago. Doug Burton looked at me, he's the chair of orthopedics, so he looked at me and said, "Stites, are you an internal medicine doctor?" And I growled back at him and I said, "Very funny, Burton. What are you saying?" He goes, "Can you think of a worse exercise for somebody with low back pain like you have to do than running?" Because that's all I did. I had to do all the strength training. So this role of strength training and stretching, personal story is that, man, that made all the difference for me. How big a deal is that for a lot of our patients?
That's a great question. And so one of the arms in the study is evidence-based exercise and manual therapy. And so that incorporates some of the things you're talking about in terms of strength work, muscle work, getting some cardiac activity, that those are all very evidence-based. But the manual therapy is a really neat portion of that arm in that it involves the role of a physical therapist or a chiropractor. So here at the University of Kansas, within our study, we have 2 licensed physical therapists who are experts in chronic low back pain, who will be assessing participants who are in that arm and identifying which types of strength therapy, exercise, and manual therapy would suit them best. If you can tell, the whole goal of this study is personalized care, which is so important in medicine. And the manual therapy is interesting because it's what the therapist can do with their hands. So these include things like therapeutic massage and myofascial release, as well as mobilization. So I can't stress enough, and I'm sure my other participant on the panel, Dr. Bunch here, will talk a lot about, and we all very much are in approval and understanding that exercise. I like to call it movement and activity because I think exercise can be a little daunting for people in pain, but just that idea that moving our bodies, movement is medicine, and that activity on a daily basis is so, so important.
Yeah, I totally agree. For me, it was all about exercise and strength and doing things besides running. I had a great this cardiovascular conditioning, and my core was so weak. And when I got the core stronger and stretched and did other things, my back pain, I think by the time I was 45 or 50, I felt better than it did when I was in my 20s, and it is such a difference maker.
Absolutely. Getting those muscles strong is a really important thing. And cardiac activity, again, is great for the pulmonary and cardiovascular system, but making sure our muscles are strong and working properly is a huge part of this as well.
It is. Well, let's bring your patient into this conversation, and then we're going to turn to Dr. Buncher in just a moment. So, Danella Ragsdale, hopefully I said all that correctly. Did I do a good job?
Yes, you did. Very good.
All right, thank you. So you're very kind. You've enrolled into this study. Tell us a little bit about your lower back pain story.
Oh my! I've always had a little bulging disc issues, but I was in a car accident, and since then the pain had slowly gotten worse. And we've tried physical therapy. We've tried ablations and epidurals and stuff, and Dr. Chadwick's been phenomenal. She's like my hero, and she's done everything in her power to relieve the amount of pain that I'm in, and a lot of it's worked. She's done a great job. She gave me the opportunity to join this STEP study, and I jumped on it. Absolutely anything I can do to help anybody to not feel the way I feel all the time, I think is a great thing. I love modern science, and as people learn more about other things and how things operate or how pain is connected to other things, I think it's important to know and be able to help everybody.
Well, thank you for being in it. And my gosh, without people being willing to participate in research, we never get to really cool advances in my field, cystic fibrosis. It took lots of patients volunteering to help advance the science, and you're advancing the science. We so appreciate that and appreciate all those people out there, because science matters. Science makes a difference. It's why we can do things so much better now, but treating low back pain and everything else we do. So what questions did you have for Dr. Chadwick when she asked you to participate in this study?
I basically asked her what it involved and what it entitled and what I'd be doing and stuff. And she explained that we'd go through the brain scans and blood testing, and we'd go through some physical therapy and everything that she has been talking about. And I've been to the brain scan, I did the MRIs, I was on one of the medications and it didn't work out for me. So we're getting ready to go to the next step.
All right, now have you tried any of the other 4 treatments being studied before now?
No.
All right. So what's your personal goal? Tell me a little bit, how has it affected your life? How has it limited you? And what's your goal for what you want to achieve from this?
My goal is to be able to function. I'm a grandma and a great grandma, and I am around my kids a lot, and we there's a lot of times where the pain has prevented me from functioning and getting out and do family outings and doing things like that. And I'm the type of person who never sits down. I just can't sit down for long periods of time. And when I'm laying in bed or laying on the sofa because I can't move, it's very emotionally difficult for me. And so with Dr. Chadwick giving me these opportunities, I'm able to play with my grandkids and go see Santa, for example. Or we went to the pumpkin patch and I actually got to go and walk around with them and do all the activities and stuff. And that's my goal, is to continue to exist. And we discussed this. It's not about quantity of life, it's about quality of life.
Yes.
And I am 100% for quality of life. And she's given me that opportunity to have that.
That's pretty special, isn't it? And I think you said it well. Look at you got disconnected from everybody, and now you're able to reconnect in so many parts of life. And when you get that disconnection, it's so isolating. It feels a little like the COVID pandemic all over again.
Right.
Really, in some ways worse because you're in pain again. So, well, Dr. Chadwick is Danielle, the poster person for this trial. And what other patients with chronic low back pain would make a good candidate? Can somebody like me be in it? Just a question.
Well, first and foremost, I want to say hi, Danelle, one of my most amazing patients, and it warms my heart to see her here sharing her story. It's very courageous and brave of her. So yes, she is a great poster person for this study. She's motivated, she is interested in improving her life, and more importantly, she met the criteria for inclusion into the study. So those of us who do research design our trials to be able to make sure that we're gathering the correct population. What's cool about this study is it's very pragmatic. You know, there's a lot of clinical trials that have very strict criteria of who can be in and who cannot be. Whereas this study is meaning to be more real world and, like I said, pragmatic. It's trying to really get a wide swath of the population so that we get those spectrums of individuals with chronic low back pain and they are represented in the study. So one of the major inclusion criteria is that you have chronic low back pain, which means you have had it for more than 3 months. And as we heard from Danelle, she's had it for years and years. So these are the type of individuals we're looking for. Additionally, other participants who would make great subjects in the trial would be persons who haven't tried these procedures or tests that much before. They would need to meet criteria for 3 out of the 4 treatments we've discussed today. And then when they're ready to sign up, they would be willing to be assigned to any of those 3 out of 4 or all 4 interventions.
All right. Excellent stuff. So, Dr. Bunch, generally speaking, surgeons recommend less invasive options first, like the ones Dr. Chadwick is helping to study, but sometimes surgery is necessary. Help us understand that. First of all, how do you know when surgery is necessary versus the medical therapy, the medical approach?
Yeah, sure. Number one, I'd really congratulate Dr. Chadwick and her team. This is a huge accomplishment and great for them and the health system. I think as a surgeon, you know, we're typically kind of the end of the line. I would echo the comments about, you know, conditioning and having a strong core, both the abdominal muscles, the paraspinal muscles in the back. That's a huge part for folks that have back pain. But some of the things that sometimes make us talk to folks about surgery, maybe sooner rather than later, would be if someone does have some kind of neurologic decline, meaning that their nerves aren't functioning quite right, or maybe their strength doesn't seem like it has been in the past, if they have weakness on one side compared to the other, if they have a lot of numbness or pain radiating down their leg, that can be a sign that maybe there's some impingement on the nerves or the nerves are being pinched. And then sometimes, you know, doing surgery to take that pressure off can be beneficial.
So what's the most common cause of lower back pain then in your patients? Is it actually like the disc pushing on the nerve, or what is the most common cause?
Yeah, the actual most common cause would be a muscular strain, meaning that we have these big, robust paraspinal muscles that run along our spines, and a strain of one of those muscles can just generate a tremendous amount of back pain for folks. Folks can also have something called discogenic back pain. So we all know that there's these cushions in between our vertebral bodies, and those cushions can actually generate pain for folks, we think. Folks can also have some degeneration of the spine. The joints in the back that we call facet joints, they can become degenerative. And then certainly folks can have other less common things like infections, trauma, whether someone has a fracture. Those are all things that can cause back pain. But again, the number one thing being a muscular strain.
Yeah, so muscular strain. Okay, that's what I'm going to always blame it on because I've been trying to weightlift too much or something. So what are the most common, or not, spinal surgery procedures for low back pain, and do they alleviate the pain or lead to a different kind of pain, and how does that all work?
Yeah, sure. We'd love to say that everyone that gets spine surgery is 100% better. I think that would be not the case for everyone. I do think that we can help a lot of folks. So I think if we're talking about nerves that are being pinched, we're typically trying to take the pressure off, and there's a number of different ways to do that. For folks that have a lot of back pain, depending on what the cause, sometimes we're then talking about actually stabilizing the spine. So if you hear about someone having screws or rods or a fusion type procedure, typically that's when we're stabilizing the spine. A lot of those folks, if we can identify the right people to operate on, then they do get better. But I think it's just really, really important that we pick the right people to operate on, and we refer to that as surgical indications. And I think it's really those folks that have tried a number of other steps before they get to us, that's when we're considering surgery, because certainly a lot of folks can improve with some of these more conservative measures before they get to us. I think we do have some fancy technology at this point within spine, and fortunately we're lucky here at the University of Kansas to have some of that technology that allows us to spare some of these muscles and create less trauma for them and allows people to recover faster. But again, I think we want to really stick to the indications because that's probably the most important thing in picking the right surgical patient.
Yeah, that is, again, this is one of the cool things I think about being lucky enough to work at a place where you can see both science and clinical medicine working side by side to help advance care and treatment of really significant chronic conditions like what Danielle Ragsdale has, because it's pretty clear that science makes a difference, and it feels like it is here too. So what is the whole recovery looking like from surgery?
Yeah, most folks, for the first 4 to 6 weeks, sometimes 6 to 8 weeks, we really tell folks that some of the most important things are trying to avoid, accidents, meaning a fall. Really trying to focus for the low back in particular, standing upright. We really limit people's activity during those first 4 to 6 weeks. We try to avoid a lot of bending activities. We try to avoid a lot of heavy lifting, and that's really just to allow all those tissues to heal. Once folks get out to about 6 weeks or so, then we allow them to start increasing their activity level. Sometimes that includes doing some further physical therapy. Sometimes folks are able to transition back into those activities on their own. And my goal for most folks is by 2 to 3 months that they're really doing pretty well, and hopefully that they say, I'm glad I did this. That's not to say that everyone, is tip-top shape by 2 months. There's certainly some folks that just get lucky and faster, and there's some folks that struggle a bit longer. Maybe it's 3 to 4 months.
All right. Well, congratulations on being in this field. It's such an exciting time as things progress so rapidly. We know you have questions at home. Send those to us on YouTube, Facebook, the Medical News Network, and now Twitter. The links are on your screen. While you do that, we're going to check in with Doc Hawk. And Hawkeye, COVID count going up, flu count going up.
Yeah, right now we have 58 active infections in the hospital, 5 in the ICU, 2 on the ventilator, 22 in that recovery period. As far as the cases go, the last couple weeks, per the CDC report, it's been a slow incline, not a steep incline like we had seen with previous surges, including Delta, not so much with Omicron. But unfortunately, we know that hospitalizations do lag cases by a couple weeks. I think we are seeing the brunt of that now. But in addition, we have influenza and RSV that we're tackling as well, in addition to those other respiratory viruses that are circulating. So this is our latest data from the health system with positive testing these are for positive admissions for influenza. And you can see the orange bar is adults, the blue bar is pediatrics. So we do have a few pediatrics as well, but we still have a fairly high or sustained amount of influenza admissions to the hospital also. So then, going from there, we're looking at our total tests. The tests remain high as well. These are both antigen and PCR tests, so a lot of these are going to be performed in the outpatient or ambulatory setting. So we can see certainly very high levels in our experience, which is really consistent with national data as well. And then moving on to RSV, we are hoping that we've seen a peak in the RSV cases nationally, but the circulation of that virus still remains quite high. And again, those very, very young patients are most at risk of hospitalization and severe outcomes, as are the elderly. And so it is a concern because unlike COVID and influenza, there is no vaccine currently, and there really is no treatment for RSV either.
Hawkeye, fortunately, not everybody who has COVID is hospitalized, and I'm one of those people. So this last weekend, I was tested positive for the first time for COVID. I'd been in the 90% or 10% of Americans who have not had it and then crossed over. I'm not really sure where that exposure came from. I'd be happy to figure it out if I could, but I think it's just everywhere, and I think the numbers are so underreported because if you do test positive at home, you do the things like I'm staying at home, working from home. I feel actually much better. And Hawk, I'm really grateful I got vaccinated. I think it's made all the difference. I've been up to date on all my vaccines and all the boosters, and so I've had a couple of bad days, like a bad cold, but I'm 5 days into it and I feel pretty darn good. Last night took a 1.5 mile walk at a fast pace and felt great, and hopefully going to get to do that again today. And I think it's just a testament, again, linking back to the science, how important that is, because vaccination, I believe, is making a huge difference in our COVID numbers right now.
Yeah, that is absolutely right. Vaccines, being up to date with vaccines, the early data is coming out about the bivalent boosters, not only looking at the antibody levels, but actually looking at that clinical data and protection. And we talked about the Kaiser Family Foundation research yesterday that really continues to reinforce the fact that those people that are fully vaccinated and up to date with their booster really do have a reduced chance of hospitalization and severe outcomes such as death. I think that's important. We understand that we have very good vaccines here. Be up to date, and that can help reduce your chance. Yesterday, I saw a patient who was admitted for COVID. Exactly, they are getting remdesivir now, but we should also continue to endorse, testing early. And if you don't have restrictions or drug-drug interactions, it's vitally important to get on Paxlovid as well, especially if you fall into that high-risk category.
Yeah, I think I actually fell into the high-risk category. One of my drugs made it hard for me to go on Paxlovid, so I'm not doing that. But I think it's really important, people, too, especially if you're immunocompromised right now, as Evusheld, which is the injection hit for patients who've been transplanted or had other significant diseases, and monoclonal antibodies don't work for this version of COVID anymore. That just means that people are going to have even better, more conservative measures. We have to remember the rules of infection control. What do they do, Hawk? They protect you everywhere you go. And
right.
you still got to make sure you keep your distance, cover your mouth, wear a mask when you're sick or you're going outside. If you're one of those immunocompromised or patients at risk, I think it's probably time to take mask wearing a little more seriously when you're out in public, given how much COVID there is out there.
Yeah, and I think so, and it's the other respiratory viruses too. And I think if you're traveling, I think it's important to continue to wear a mask. We know very, very small percentage of the people in the airports and the planes are wearing their masks. I would encourage you, just so that when you get to your destination, you aren't feeling ill and having to be bedridden with symptoms and things like that. So do everything you can to protect yourself, whether you're home or traveling. I think that is some of the best advice we can give.
The CDC is reporting that the U.S. is experiencing the highest levels of hospitalization from influenza in a decade. Yeah. Does that surprise? It doesn't really surprise me. This disease comes up and down all the time. Does it surprise you?
Yeah, I mean, the impact certainly does. We kind of expected it in 2020 initially, at the end of that flu season when the pandemic first started. We didn't really see it in 2021 or the winter of 2020. I think we are seeing it now, and I think it's just so stark that there is such a change over the last decade. In fact, the CDC reported that in week 46 versus week 47, which is their most recent data, the hospitalizations for influenza doubled. And so I think that is a very high impactful piece of data to understand that people are getting the disease, they are getting hospitalized with this. But there is a sliver of hope, as the CDC right now, in their earliest estimates, says that the vaccine strains are a very good match to the current circulating strains, so you should get fairly good protection against that as well.
Yeah, they had just pushed that heat map for influenza up on the screen, and it does show a lot of purple and deep red, and I think that's a concern. But also you can see, unfortunately, Kansas and Missouri, we have room to go higher, and we're already seeing a lot of admissions for influenza on a weekly basis.
Yeah.
We're seeing influenza deaths. So, it is a challenge for us this winter. We probably have 70 or 80 COVID plus influenza plus RSV patients currently in the hospital. That's like 2 or 3 units of the hospital. That's actually a lot. We've gotten so used to having all these patients in that it's kind of like, okay, well, it's business as usual. But the reality is, if you want to turn the clock back 3 years, we'd say, holy cow, this is a lot of folks in there. And do you guys have the heat map for the COVID numbers there? Yeah, there you go. So the COVID thing, this is a COVID map, and you can just see it. And we kind of look at this on a weekly basis. It's beginning to take off on a regular basis. And I think we have a couple of other COVID screenshots you can pop up. Right. So this is the new reported cases. Now, what Hawkeye's other point is that the numbers aren't going up very fast yet. The challenge to us is this. This is vastly underreported. What I also want to point out is that only about between 20 and 30% of Americans are fully boosted, which means as we come into this new era, the BQ1 and BQ 1.1, we're probably even more vulnerable than we think. If you went back to some of those earlier peaks, if you go back and look at the earliest part of those curves, they start to crawl up and then they escalate up. We're going to have to see what happens with COVID over the next month or so to see if those numbers really rapidly increase. One of our challenges is we're starting from a high enough baseline right now. Now the hospital's already pretty darn full. Next slide. I think there's another slide after that. Yeah, this is just we're talking about reported cases by day, but then if you look at it, you can even see the test positivity rate is going up pretty rapidly for COVID, and we're seeing the rise. If you go to the on the top right corner there, you can see the rise in hospitalization and ICU numbers starting to escalate up a little more rapidly. We'll just have to see where that goes. So far, deaths have not increased, but we know deaths could lag 2, 4, 6 weeks behind the number of hospitalizations. So I just think we have to be aware that there is a lot of COVID out there, and even I try to have pretty good behavior, Hawkeye. I know that you do. Mm-hmm. At some level, we've all had to return to a little more normal life, and I think that just puts us a little bit more at risk for our patients out there who are more immunocompromised, are significantly have significant chronic illnesses. You just have to be aware of what you may be headed into, and remembering that while Paxlovid works, if you have the things that mean you can't take Paxlovid, monoclonal and Evusheld aren't really available until there are new formulations more directed to BA1 and BQ1 and BQ 1.1. Jess, do we have any questions out there today? I bet we do.
We do. Good to see you today, and your cat.
Hey, good morning. Hey, I look pretty cool. Do you notice I'm sporting my KU Health System vest on? I'm starting to let the beard grow back.
You got that? You need to get your laundry done. That's not hanging on the back of your door, and your kitty cat just walked behind you.
That is not laundry. Okay, you think that's laundry? You know what that is?
What?
2 are outstanding people in research here today, and that is physical therapy equipment. That's our
okay. Trying to figure out what it was.
It's keeping in with Show Me the Science. Thank you very much.
Okay, fine. All right. I'm sorry. But okay, it's good to see you, by the way. I hope you're feeling better. So yeah, a couple questions. Talking, and I want to. Good. I want to bring you and Hawk in on these, but question from Rebecca. Can you speak to Novavax versus mRNA? She says she's read Novavax may be better at working against new variants.
That's a really great question, Hawkeye, and we don't probably talk about Novavax amounts. I mean, J&J is kind of out of the picture for the most part, but Novavax is still pretty highly thought of, and it's a very traditional vaccine. For people who may be afraid of mRNA, you don't need to be afraid of mRNA, but for people who might be, Novavax, good vaccine.
Yeah, I would agree. I mean, there's not as much clinical data for various reasons, including just the uptake of that vaccine hasn't been as much. And I think it recently did get approved as a booster as well. So, but it does provide protection. And so, if you are reluctant to get the mRNA vaccines, I would certainly get the Novavax vaccine. It does continue to provide protection as well.
Another question for Dr. Chadwick. This viewer says, super interesting, this information you're sharing this morning. Are you trying to figure out the cause of the pain or the resolution to the symptoms?
That's an awesome question. So it's actually a little bit of both. So we have a pretty good understanding about the mechanisms of chronic pain. And with chronic low back pain, it's just like Dr. Bunch said. There's muscles, there's bones, there's discs, there's nerves. But there's also the impact that having chronic pain has on the central nervous system, which can perpetuate and maintain that pain even if there's the inflammation in the spine resolves. So what this study is trying to do is gather, are there predictive measures of patients that allow us to predict the outcomes? So we are trying to get into those mechanisms, but a big part of the study as well statistically will be to analyze the data to see what treatments work best for which patients.
And another question for you is from Greg. Dr. Chadwick, do I need insurance to participate in this trial? And who pays for the doctor's visits for the tests? And will I know my results?
So those are all great questions. The beautiful part of being involved in clinical research that's funded through our government institutions like the National Institutes of Health is that the grant fully covers all of the tests and treatment visits that participants who sign up and enroll in the study will participate in. So no insurance is required because we don't bill anything to the insurance. And then all of their treatment costs, visits, etc., will be covered fully by the study. In terms of knowing the results, there's a lot out there in terms of when research is completed on a large scale like this. It's actually required by the National Institutes of Health that those results are disseminated publicly. So all of the results that will come from this study and any other study design parameters that come from this study will be available through PubMed, and I assume that they'll do a really wonderful job of disseminating those results through press releases and things like that.
Dr. Stites, I'm going to make this my last question because I know Dr. Bunch needs to get to patients here in just about 5 minutes. So Rebecca wants to know, is Paxlovid being used for 2 rounds if you're high risk? She's heard that some doctors do this, but it's not industry standard. Why not, since rebound is somewhat common?
Yeah, I'm gonna have Hawkeye and I can double team this. Hawk, I think we ought to kind of stand more with how it's supposed to be used, opposed to going off label with a drug that's not had as much history around it or quite as much experience around it.
Yeah, that's exactly right. You know, the emergency use authorization is certainly only for the 1 round. They have looked at people who've had the rebound. There isn't more severe disease. You aren't more at risk of going to the hospital. So right now, the standard and the recommendations continue to be just that single round of Paxlovid. I think we are open to studies and data and information talking about either a longer course or receiving a second course, but at this point in time there is no recommendation, no formal recommendation for that.
Yeah, it's that's how I would look at it as well, and yeah, like I consider I'm technically fall under a high risk category just based on age. Don't anybody laugh at that. But you don't have to take Paxlovid. You can make a choice depending on how you feel like you're doing or what the course of illness is. Thoughts about how to select for that?
You know, I would say most people who are at risk should. I think number 1, you should be up to date with your boosters. Obviously, if you cannot or have not been able to take the vaccines or they anticipate you don't have a good response, getting on Paxlovid. But then it really just goes to you as an individual and talking with your medical teams, assessing your own risk as well.
Yeah. All right. Well, this has been a great discussion today, and I always look forward to these Show Me the Science episodes because I learned so darn much myself, but I hope our audience does too. I bet they do because I think these are terrific, and I want to thank all of our guests. I especially want to thank our patient today, who it's always great to hear the words from a patient who's participating in these things. So Danielle, we're going to go through final thoughts. I want to start with you, and I really want to say thanks for being a part of this study, being a part of this program and helping advance the cause of folks who have back pain.
Thank you for having me be a part of it. It's exciting, and I can't wait for the next step.
And I'm really glad you got to go to that pumpkin patch and do things like that. That's awesome. And I bet your grandkids are delighted that they're able to spend time with you there. Dr. Andrea Chadwick, final thoughts.
Well, again, just thank you, Danelle, for participating. I always say to my patients, and really anyone who will listen, that although we are medical experts and know science, patients have a lived experience of their condition, and therefore they are the experts of what's happening with their bodies. So for Danelle to come on here and share her story, I know that many people across Kansas, or anyone who's listening, will feel like they are in good company because they are getting their voice heard through Danelle today. And for anybody who's interested in our study, please contact us. We would really love to hear from you so with that we can move forward with this groundbreaking research.
That's and I completely endorse. I loved your point about every patient has their lived story about how they've had to struggle with disease, and it does make it. It's different. We all handle that and receive that a little differently. Dr. Joshua Bunch, thank you for being on the program today. Always appreciate our orthopedic surgery colleagues and what a difference that can make.
Yeah, for sure. My pleasure. Again, congratulations to Dr. Chadwick and her team, and really appreciate the opportunity to chat this morning.
Doc Hawk.
Yeah, I mean, I think it's just continuing to endorse the message that we have. We know influenza rates are still going up. Hospitalizations are still high. RSV as well. There are those other cough and cold viruses. I think there's something that is going around the community, probably rhinovirus or one of those other common cough and cold viruses. But of course, SARS-CoV-2, and we've seen our numbers here, our COVID hospitalizations. Vitally important to get boosted if you haven't. Be up to date with your vaccines. And again, if you do have symptoms, please try to test early. And if you do meet that criteria and are high risk, certainly recommend Paxlovid.
You know, I'm always impressed by these programs. It's a reminder of how far we've come in medicine. I've told the story many times. I've been in treating patients with CF, and when we first started it, and life expectancy was 16 or 17 years, and now it's 53 years and climbing because of new therapies. And now it's going to be a disease you're going to live with chronically, with I think more and more of a normal life expectancy. Who would have thought? And the ability to get up and do things and get back to the pumpkin patch and Christmas tree shopping or going outside and walking with back pain is actually pretty revolutionary for a lot of people. And I think it shows us what science can do, as opposed to trying to be out there and creating rumors and innuendo and a cancel culture and all the stuff that the internet can do. We also have to remember the internet can be a powerful tool for education, for research, for recruiting people in, and for learning and doing things and advancing science like back pain, or frankly vaccination, the mRNA vaccines, which are miraculous, successful, and safe. And that's why we can be so much safer in this pandemic. That's why I'm able to stay at home feeling well, ready to come back to work after having COVID for only 4 or 5 days. So Jess, back to you.
All right, Dr. Stites, thanks. Get well, get back to us soon. And thank you all for joining us today. We'll be back tomorrow morning at 8 a.m. with another Morning Medical Update. Until then, have a great day. Coming up tomorrow on the Morning Medical Update, it was a shocking diagnosis. Non-cancerous tumors threatening 23-year-old Alex Teeter's brain and spine. I'm Jessica Lovell on the next Morning Medical Update. Alex was one of the first proton therapy patients at the University of Kansas Cancer Center. Did it work? How did it feel? And what's next for this college student? We'll tell all Thursday at 8.
I'm Alexis Delcid. Next, All Things Heart.
It was like 2 a.m. I couldn't sleep. My heart rate was just out of control.
As a med student, she knew all the signs and symptoms of this autoimmune disease, and she still wrote it off as stress. The risk to her heart and yours if you have this and don't get it treated, Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.